Hi, everyone, and welcome to the Parkinson's Foundation's PD Health at Home Wellness Wednesdays. Today's topic is deep brain stimulation. Deep brain stimulation, known as DBS, is a surgical treatment option that can significantly improve the quality of life for individuals with Parkinson's disease by helping to manage symptoms that may not be fully supported with medication. This webinar provides an in-depth look at what DBS involves, how it works, and who may benefit from the procedure. Today's attendees will hear from a medical expert and individuals who have undergone DBS, learning about the preparation, procedure, and the potential outcomes. Today's program is presented by Abbott. Your partnership makes a meaningful impact. Thank you to our sponsor, Abbott, for their generous support and helping us advance our mission. Thank you, Abbott. Before we get into it, I want to remind you about our other PD Health at Home virtual programs. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, our expert briefings, and our Spanish language series, AP Salud en Casa. Be sure to visit our website to see what's coming up and explore our archive videos on YouTube. Help us spread the word and make a difference in our Parkinson's community. I'd love to introduce our first panelist for today's session. Rich Bond is a television director and executive producer known for Last Call with Carson Daly. In 2015, at the peak of his career, he was diagnosed with young onset Parkinson's disease, a life-changing moment that reshaped his path. After struggling with symptoms and ineffective treatments, he found expert care at Columbia University. Deep brain stimulation surgeries in 2023 and 2024 dramatically improved his quality of life, restoring hope and reducing his reliance on medication. Despite Parkinson's, Rich continues his creative work, co-executive producing Angels of Hope and collaborating with nonprofits like the Parkinson's Foundation. As a brand ambassador for Abbott Technologies, he advocates for DBS and shares his story to inspire others, and he embraces resilience, purpose, and the belief that life beyond diagnosis is still full of possibilities. Rich, if you would join us, please.
Hello.
Hi, thank you so much for being here. How are
Thanks
you
for having me.
feeling today?
Feeling pretty good today. Thank you. Thank you for asking.
I'm so glad. I'm curious, Rich, if you could share with me what life was like before you considered deep brain stimulation. What was Parkinson's like for you before?
It was not fun. It was not a good situation, and it was progressing. It started off very slowly. I was diagnosed in 2015, misdiagnosed in 2007 since 2012. But around 2018 or so, it really was getting out of control. I was maxed out on medication. And life was just very difficult on a daily basis. There's always something to be dealing with, whether it was the Parkinson's itself, or from, in my case, the side effects of the medication were just as bad as the symptoms of the Parkinson's.
What concerns or perhaps hesitations did you have when you first thought about DBS?
Well, I used to joke about it that everyone says, "Well, it's not brain surgery," and I'd say, "Well, this actually is brain surgery." So, you become the butt of the pun. It's just you become the end of the joke. So I mean, obviously you're concerned about it's brain surgery and it's scary. It's something no one ever thinks they have to deal with, and when you do, it's kind of shocking.
Mhm.
Even though when it's explained to you and it's not as serious of a surgery as you may think it is. I mean, obviously it's serious, but it's not. It's something common that's been done so many times, so you get a little more used to it. And towards the end, I was just ready for it. I could not. I had nothing else. The medicine was not working, and I had no hope for anything else. So,
What was the moment like when you said yes, Rich? It was, yes, I am getting DBS.
scary. Definitely scary. Definitely, just something. Again, something you'd never thought. If you asked me 10 years ago, even when I was battling Parkinson's, if I was going to have surgery, I probably would say no. I don't. I never knew about it. Never. I knew what it was, but you don't really think about it happening to you. But when I after I said yes, slowly but surely, I became more and more confident. I was ready for it. So.
Can you walk us through your experience with the DBS procedure?
So in my situation, we were dealing more with the dyskinesia and dystonia, and dyskinesia really being caused by the Cinemet, the carbidopa levodopa that I was on, and the mass amounts that I was taking just to be able to function.
Mhm.
We decided, and it was really generally my left side was really bad. My right side was not really showing too many symptoms at the time. So I had two surgeries. So the first one on the right side of the brain and more of the frontal lobe here,
Mhm.
to deal with the dystonia and the dyskinesia, not so much the tremors as much, which is more the what the average person with Parkinson's goes in for, is really the tremors that are really bothering them. Um, but it just when the I'm sorry, what was the question again? I'm sorry.
Sure. Your experience with the procedure of
Oh, the
DBS.
procedure, yes. So I
Mhm.
mean, you go in and like I said, you think it's brain surgery, but next thing you know, you go into the surgery, you come out, you have a little, I'm bald, so when I shaved my head, so I had a little mark here, and it was amazing that there's no lump or anything. That my surgeon, Dr. Brett Youngerman, shout out, great surgeon. I told him, don't forget I'm bald. I don't want any antenna sticking out. So I mean, and then I called my USB port here in the back. That actually had more of a cut in it than the actual where you go into your brain. So it's just kind of like, it's amazing. And then one night and next day they walk you around and you go home. It was pretty remarkable.
Wow. And how did getting DBS, how did that impact your daily life?
Um, so it was about 2 weeks before I went back and for them to actually turn it on. So they turn it on when you have the surgery. Because I had the IPG placed the same day.
Mhm.
So I had one side done, so they did that and the IPG, which is basically your control center. That was turned on slightly, so I felt the difference already, but it wasn't completely different from how I was feeling before. But the minute I went into the office and they turned it on, I mean, I went from my hand shaking like this to it just stopped right there. It was absolutely amazing. So it literally was in the moment when they turned it on. I felt my life change right there. I mean, it was just it felt a tremendous amount of thankfulness, appreciation for everyone who helped me to get to that point. And it was just it was hope. It was hope. It gave me hope again because I had lost hope. It was not, like I said, it was a bad, bad, bad place that I was in at that point. So
How, Rich, when we spoke previously, you'd shared how life was so different before DBS and after. Could you just share a little bit about how DBS changed your willingness to engage with life again, with the activities, your relationships?
absolutely. I mean, before the DBS, like I said, it was so bad that you couldn't enjoy a meal, you couldn't enjoy a conversation, you couldn't lay down and rest and not and feel like you're actually getting rest. Everything just felt like it was a chore. Every single thing you did was you do on a daily basis that you don't need to take for granted completely. Getting dressed, taking a shower, making food, eating food, speaking with somebody, having patience. I had no patience whatsoever before the DBS. I was out. I had run out. I could not deal with it anymore. And once I had the DBS and that was gone, it brought me back hope. I was in my story that's on parkinsons.org. I refer to myself as the Tin Man because I honestly feel that I got my heart back through the DBS and the IPG, and the medication that I still take is my oil that keeps me moving. So it's just kind of you got to oil me up every 3 hours or so, and then I keep going. And everyone says take it day by day. I say, well, it's more like every 3 hours by 3 hours by the medication that you take. So it's but since the DBS, I mean, it went from a very dark time to a very bright time. So
I'm grateful that this is has been an option for you that was so significantly beneficial, Rich. I have one last question for you,
sure.
if you'd allow me.
Mhm.
What do you wish more people knew about deep brain stimulation as a treatment option for Parkinson's?
I get asked this a lot because I'm part of some support groups that for people who are debating whether or not they should get DBS. And I tell them the two things about it is one, this is something that's been around for quite a number of years. It's not everyone thinks it's a brand new procedure. So no, this has been going on since I think the 70s, I believe it is when they first started it. I mean, it's come a long, long way. It's very safe. You surround yourself with great doctors, just like I have at Columbia. And just don't. You can be afraid, but you got to find some hope in that fear. There is light in darkness. So and DBS is that light. So
Thank you so much, Rich. And letting our audience know that you're going to be sticking around for questions later on. So if you have questions for Rich, submit them in the Q&A. And Rich, thank you for the inspiration and the courage to share your story. We'll see you again
thank you for
soon.
having me. Yes, thank you.
And now I'm thrilled to welcome Dr. Mason, Assistant Professor of Neurological Surgery and Neurology at the Keck School of Medicine at USC. A graduate of Harvard University, Dr. Mason completed his neurology residency at Brigham and Women's Hospital, Massachusetts, followed by a fellowship in movement disorders at UCLA. As director of the USC DBS program and the USC Musicians Neurology Clinic, Dr. Mason specializes in procedural therapies for movement disorders with a focus on deep brain stimulation. His research also explores musicians' dystonia and other occupational movement disorders, working to improve treatments for those affected. Please join us in welcoming Dr. Mason. Thanks for being here.
Thank you. Thank you so much for having me. So it's an honor to be here and an honor to speak, especially alongside some specific patients who can share their journey. Thank you so much, Rich. And I'm going to be happy to take questions at the end. So I've hopefully left enough time to do that, and we'll appreciate answering anybody's specific questions about any of this content. The first thing I'd cover today is just relevant disclosures. So this talk was sponsored by Abbott Labs, one of the DBS device manufacturers. They did review the slides and suggested specific changes to a few slides at the end of the talk where I speak about some capabilities that are coming down the line, but not currently FDA approved. So those are marked with an asterisk, and I'll clarify those when I get there. I
Dr.
wasn't
Mason,
compensated in, yes?
we cannot see your slides.
Oh, okay. So let me try again.
Thanks for allowing me to interrupt you.
Can you see them now?
Yes, perfectly. Thank you.
Great. I think that's the only time I haven't asked in the last 3 years or 4 years of Zoom, and it's the one time. But thank you. So I wasn't compensated for this talk. I do receive consulting and travel fees from Abbott Labs and Boston Scientific, who are two of the device manufacturers, and I have a research interest with Medtronic, so that's the third device manufacturer. Those are my relevant disclosures. So we'll talk about the history of deep brain stimulation today, and Rich already spoke about how long DBS has been around and that it's not a new technology. But I will cover that a little bit. And then importantly, we'll speak about how deep brain stimulation works, the factors to consider when you're thinking about deep brain stimulation, who, what to expect, when to do this procedure, where we can do the implantations, how we can do the implantations, and what devices you might consider choosing. And then at the end of the talk, I'll speak about some new innovations and future innovations. DBS has its roots in neurosurgical procedures that date all the way back to the 30s and 40s. And at this stage, there was an invention of a technique that allowed neurosurgeons to access the deep parts of the brain without having to expose large areas of the brain. And so it was a much safer method. And they also didn't have to move around too many structures superficially. So this allows us to have access to areas of the brain that are relevant to Parkinson's disease without causing too much damage superficially or exposing people unnecessarily to open procedures. In this period, there was some investigation of um, where we could make small areas, lesions in areas of the brain in order to treat symptoms of Parkinson's disease. And then there was a period in the 60s, 70s, 80s where medications for Parkinson's were discovered, and there was relatively less interest in surgical treatments for this disorder. But then in the 90s, there was a resurgence of interest with the discovery that instead of lesioning the brain, we could apply constant electrical stimulation to specific small areas of the brain and affect the same result. So the first case of deep brain stimulation of the subthalamic nucleus was done in 1993. And then of the globus pallidus, which is the other target that we consider for Parkinson's disease. And then there was FDA approval finally in 2002 of deep brain stimulation for Parkinson's disease. And now, 23 years later, we have 3 device manufacturers constantly updating their technologies and providing us with better and better ways to treat our patients with this technique. So how does this work? Well, at a very simplistic 20,000 foot level, deep brain stimulation consists of three components. You have a battery, which is similar to a pacemaker, implanted in the chest that's under the collarbone. You have a wire that connects that battery to two electrodes, which are also called leads. And the leads are implanted through small holes that are made in the skull during the surgery into the deep areas of the brain, and they apply constant electrical stimulation. And by doing this, we can relieve some specific symptoms of Parkinson's disease in specific cases. So I want to prime you with a concept before explaining what deep brain stimulation does at again, a 20,000 foot level. Parkinson's disease, as it changes over time, changes the way the brain responds to medications. And so as we're thinking about important phenomena that we understand are parts of later stage Parkinson's disease or moderate Parkinson's disease, wearing off and dyskinesia or excess movements, this is really the Parkinson's disease affecting the brain and changing the way the brain responds to the same medication. So early in Parkinson's disease, that medication, and the most important bread and butter medication is carbidopa levodopa, works very, very well because the brain is able to take in that medication, respond predictably, and deliver good, even symptom control throughout the day. As Parkinson's disease progresses, the brain's ability to take in that medication and the way that the brain responds to the same doses of that medication changes. So what you develop are fluctuations. So with the same doses of medication, you might have times of the day where you have excess movement. That's in this upper pink area, and times of the day where the medications have worn off before the next dose is due. So we call those respectively dyskinesias or wearing off phenomena. And then as Parkinson's disease progresses with time, those dyskinesias can become worse, and people spend more of their day in that period of time where they have excess movement, or that period of time where their meds have worn off, and very little time during the day where the meds are working and not causing either one of those two effects. So what DBS does is broaden that window. So before DBS, the doses of medications, they cause these fluctuations in the amount of medicine in the brain that might cause excess movement, and then as the medicine wears off, cause wearing off. What deep brain stimulation does is widen that window so the brain can respond evenly to the medications. So with the same doses of meds, or sometimes with lower doses of medications, symptom control is much more even. And the mechanisms of deep brain stimulation, neurophysiologically, electrophysiologically, those are still very much being worked out. We're starting to understand how the brain's networks might change in response to DBS, and how the electrical circuits might vary, and how information flow from one area of the brain might be affected by deep brain stimulation to another. But for the most part, our understanding of the exact mechanism of DBS is incomplete. So now then, we'll take a step away from that 20,000 foot view and narrow down to the individual level so that we consider for you what time might be the best to think about deep brain stimulation, whether you'd be a candidate, and what you could expect from the procedure. So first, who is appropriate to undergo deep brain stimulation? Are you a candidate for this procedure? The important factors are listed here. First of all, a diagnosis of Parkinson's disease. And this is in distinction to some conditions that can look like Parkinson's disease, especially early on, but that behave differently over time. And those include Lewy body dementia, or progressive supranuclear palsy, PSP, or cortical basal degeneration, CBD, or multiple system atrophy, MSA. So some of you might have heard those terms, so I just list them here because we avoid doing deep brain stimulation in those conditions. For that reason, we want symptoms to have begun more than 5 years ago. During that 5-year period, we can be much more confident in the diagnosis of Parkinson's disease and much more confident that deep brain stimulation is an appropriate treatment. So usually we don't do DBS for the first 5 years after diagnosis or first 5 years after onset of symptoms. We also want your symptoms to respond well to medications, and there are exceptions to this that I'll get into. So your symptoms have responded to meds in the past, but now you've developed bothersome on and off, wearing off phenomena. That's that low period. Or dyskinesia, those excess movements, that's that upper period. So you're fluctuating up and down. And how I like to describe it is that we're beginning to be between a rock and a hard place. So we may be in a position where increasing the medication would be appropriate to allow you more good on time throughout the day and reduce those wearing off periods. But if we do that, we might worsen the dyskinesia, worsen the excess movement. So that's that rock and that hard place position. When we're there, deep brain stimulation can allow us, it basically moves the rock back. It can allow us a much better window to treat you satisfactorily with medications. Finally, five, we want symptoms which respond to medications to be the symptoms which are most affecting your quality of life. We really look for that match. And finally, there is a condition where some people are unable to take carbidopa, levodopa, or similar medications due to severe side effects. In this case, deep brain stimulation can sometimes be useful, even in absence of points 3, 4, and 5. So what benefits can you expect? These are unique to every individual. And so no surprise, your neurologist is going to discuss which of your specific symptoms may or may not respond. In general, gait, that's walking, and balance symptoms are the least likely to respond to deep brain stimulation. And other symptoms, which I'll get into, slowness, stiffness, tremor, those are the ones that are most likely to respond to DBS and to stay well controlled throughout the course of the day. How likely is DBS to be beneficial? This is the question that I often get from people. How likely am I to get benefit from this procedure? So if we choose the person correctly, and if we inform them correctly and understand what their symptoms are, and set expectations of what the surgery can do and can't do, then there's a very high likelihood that we'll get improvement in the symptoms that we're looking to treat. So that's, I would say, greater than 90%. The trouble comes when there's an expectation that symptoms which were or shouldn't have ever been expected to respond to deep brain stimulation then don't respond after the procedure. So that's that importance of education and expectation setting. How much improvement do you get in your symptoms? Well, that really depends on the symptoms. Generally, tremor, stiffness of the muscles, and slowness are going to improve substantially or nearly completely, and other symptoms are going to improve relatively less. So here's 3 rules of thumb in terms of what to expect, because some of this can get a little bit confusing. But if you remember these 3 things, you'll have a good sense of what deep brain stimulation can do broadly in the population, and perhaps have an insight into how it could help you specifically. Rule of thumb number 1, symptoms which improve with medications, especially those with fluctuations throughout the day as you take your medication doses, things that get better with the med and then wear off as the medication wears off. Those are the ones that are most likely to respond to DBS and be well treated throughout the day. So tremor, stiffness, and slowness are often, those are the 3 symptoms that respond best to meds, which is why I mentioned them in the last slide. Rule of thumb number 2 is that deep brain stimulation generally can only do as well as the best medication dose. There's the best medication on time throughout the day. So if you typically feel better mid-morning and feel the best mid-morning, you can imagine that that best period of time is going to persist for longer throughout the day after the deep brain stimulation surgery. Sometimes people feel really good in the afternoon, but they have some excess movement, some of those dyskinesias, and deep brain stimulation does suppress those in addition to reducing the wearing off. So you have to consider that you're going to have your best on time, though without those bothersome excess movements that are called dyskinesias. And rule of thumb number 3 is that the symptoms which are present when the meds are working their best and you feel the most on, that's a term that physicians and people with Parkinson's disease often use, those symptoms are likely to persist after deep brain stimulation. And the most important one that people often ask about is difficulty with walking. So sometimes people have freezing or slowing of their gait that improves with doses of medications. In that case, deep brain stimulation can be useful for walking and balance and gait, but it's often the case that people have slowness or sometimes freezing of gait. Those are the stutter steps that often stop you in the middle of your gait or when you're just starting to walk after sitting down for a while or as you're turning. That can sometimes persist even when the medications are working their best. And in that circumstance, we can't expect that the surgery is going to help that symptom. All right, so just to review the rules of thumb, symptoms which improve with medications are most likely to respond to surgery, but they'll be more well controlled for a longer time during the day. The best that surgery can do is your best on time with medications, though with reduced wearing off and dyskinesia, and then the symptoms which are still around despite the best on time are unlikely to improve. The exception is tremor. So tremor, if it doesn't respond well to the medications, does respond better to surgery in many cases. All right, so that's the one exception, is that if you still have a lot of tremor despite taking really high doses of medication or frequent doses of medication, we can probably improve that tremor with deep brain stimulation. So what can you expect? What are the risks? Bleeding in the brain can happen when we place the electrode, otherwise known as the lead. That happens in about 2 to 3% of implantations. And only 1%, or in some studies, less than 1% of the time, is that bleeding symptomatic, or does it cause any problems or symptoms? And when it does cause problems, those would sometimes be similar to a stroke. You can have weakness on one side of the body, but again, that's less than 1% of implantations. Infection from the surgery or battery placement happens in about 2 to 5% of cases over the long term. As that battery comes in and out, as it's replaced every few years, there's a risk of infection with each of those replacements. Our surgeons do a really good job of placing the electrode in the right place, but between 1 and 3% of the time, we have to move the position of the electrode even months down the road because we're not getting the effect that we want. There's a risk of malfunction of the hardware, which is around 3 to 5%, although likely lower these days. And then problems with the battery that's placed in the chest. Specifically, it's about 2 to 4%. You can also have side effects of the electrical stimulation itself. And as the technology has advanced over the years, these are becoming less and less important. We can always just turn the electricity off if there's persistent side effects. So these are generally less important. And we can almost work around these, or we can almost always work around these during the programming sessions. I'll explain exactly what those look like. This is your brief summary of the journey of undergoing a deep brain stimulation implantation. So the first thing that you'll do is be evaluated by a specialist neurologist like myself and a neurosurgeon. You'll have a specialized MRI scan that allows the neurosurgeon to place that lead in the right place. And then you'll also usually undergo a neuropsychology evaluation. And that's to understand your cognitive symptoms, any changes in your thinking, or any emotional symptoms, psychiatric symptoms like depression or anxiety. Those can influence how we do the surgery or where we place the electrode in the brain. Then you'll undergo the first stage DBS implantation. This is the big one where the electrode is placed through the holes in the skull. This generally requires a general anesthesia. Requires a general anesthesia and can be done asleep or awake, and I'll cover that in a few moments, and requires 1 or 2 nights in the hospital. A couple weeks later, you'll come back and have the battery placed in the chest and then connected to the electrodes from a wire that goes under the skin of the neck. That's usually done as a day surgery, so you'll go home the same day. And then you wait 2 to 4 weeks for any inflammation in the brain around the electrode to go down. We want the brain to settle. We want the electrode to be free of any surrounding fluid that can come with inflammation. And then we turn it on. And somebody like me, a specialist neurologist, will determine exactly where on the electrode to deliver the electricity and in what way to best treat your symptoms. That usually requires a couple of visits in the first month, and then we can start to space out the visits. But you do have to come back every 2 to 3 months to check on the device and to change the programming, so the way that the electricity is delivered specifically by the device, in order to treat your symptoms over time. So we can change the stimulation pattern or location slightly as you develop symptoms over months and years in order to compensate for those new symptoms. So in general, this process from beginning of evaluation to where we're really reaching a steady state where you're feeling better and you're only coming to see us every 3 months, you're looking at about a year. But that initial programming period lasts about 2 months. The surgery itself happens over about a month, and the evaluation happens over about 3 months. So it can be a bit compressed. But I generally tell people from the very first time I meet them until they feel good and they're really ready to go on a trip and they don't really have to think about the DBS too much anymore, you should be expecting somewhere around a year. When's the best time to undergo DBS? It's in this it's in this moderate period where you have the fluctuations up and down. In general, there's no age cutoff. In general, we want to fulfill those 5 to 6 candidate criteria that I listed on the previous slide. And in general, we want to do deep brain stimulation before this advanced period. And there's no line, there's no cutoff that says you're in an advanced period of Parkinson disease, but we want to do surgery when it can best help you. So that those symptoms, which typically don't respond to medications, freezing of gait, or perhaps cognitive or psychiatric symptoms, those haven't become as much of a concern. As those begin to affect quality of life, deep brain stimulation can't improve those. But in this moderate period, where fluctuations in symptom control throughout the day are the main impairment in quality of life, they're the main thing that's preventing you from doing the things that you want to do or from being with people and socializing. It's in that period that deep brain stimulation can make the biggest incremental benefit and can make can have the best effect on your life. How long does deep brain stimulation last? In general, the answer is as long as the device is in place and as long as the stimulation is on, it will have benefit. This data is limited by the amount of time that we've been implanting these devices. And so when I say 10 to 15 years or longer, for tremor, stiffness, off and on, and dyskinesia, it's because this is really the longest period of time that we've been able to study these devices. So it's likely that for the duration of your life, for as long as this deep brain stimulation device is in place, it will improve your symptoms. There's some data to suggest that specific symptoms like stiffness of the trunk and the back, and sometimes just slowing of movements respond for relatively less time. And then we know that certain symptoms don't respond to DBS, were never expected to respond. And again, that's the posture and gait problems that I mentioned, the walking difficulty, freezing when it occurs in the best on state, swallowing trouble, memory problems, mood problems. These are things that we can't expect the deep brain stimulation to improve. All right, so let's go over where, how, and what to choose. I've hinted at this, but we can implant those electrodes, those leads, in one of 3 places in the brain. We almost always choose one of the first 2. The GPI or globus pallidus, the subthalamic nucleus, STN. These 2 targets have relative advantages. The main advantages I've listed here. The GPI gives slightly better dyskinesia and dystonia control, if those are important symptoms for you, although we can usually affect good control even with the subthalamic nucleus. And the STN allows us to much more dramatically reduce the doses and frequency of medication that you take. So you have to take less medication. And that's not something that the globus pallidus can offer. They both offer excellent improvement in quality of life. They both offer improvement in symptom control. And so depending on your specific symptoms, one target might be better for you. The VIM nucleus, this is a specific nucleus of a different part of the brain called the thalamus, is specifically useful for tremor control. And we rarely choose that when somebody has Parkinson's disease, but it is formally an option in very, very specific cases. The surgery can be performed in one of 2 ways. It can be done when you're entirely asleep in the tube of an MRI scanner, or it can be done with you being under general anesthesia and then being awoken for a period of time during the surgery, around 30 to 60 minutes, to do examination testing and to record signals from the brain. When you're asleep in the MRI scanner, the MRI takes many, many pictures of the brain and allows us to place the electrode using image guidance, using guidance from those repeated MRIs. So we insert the electrode a little bit, we take an MRI scan, we insert it a little bit more, we take an MRI scan, we might change the position. So the way that we're fine-tuning the position of the electrode is using the MRI. When you're awakened for 30 to 60 minutes, we use different pieces of information to accomplish the same thing. We use recording from the brain, and we use the physical examination testing. Both methods provide very similar degrees or equivalent degrees of symptom control. They both have the same risks in terms of long-term side effects, and so both are equivalent. So it's good to go to a center that can offer you both, or at least discuss the benefits and disadvantages of both methods with you. What to choose? So as I've said, there are 3 device manufacturers currently FDA approved in the United States. These are Abbott, Boston Scientific, and Medtronic. And I'll say right off the bat, any of these devices are going to affect very similar symptom control. So they're all going to help you. So if your center that's the closest to you really prefers one device over another, that's probably the most important factor, because it means that the doctors and nurse practitioners and physician assistants who are going to be doing the programming at that center are most comfortable using that device. And that's going to be the thing probably that makes the biggest difference in terms of how quickly you achieve good symptom control, how quickly you achieve benefit, and how likely it is that that person's going to be able to fine tune the device really well for you. Other centers, are comfortable with all three devices, and that's fantastic. And in those cases, I can discuss the risks and benefit, the advantages and disadvantages of each device. The Abbott device has the most simple interface for you as the patient and for the physician. It's also the only device right now that's capable of remote programming. And by that, I mean that your doctor can connect to the device over the internet. You can be at home. The doctor can be in their office, and you don't have to come in every 3 months. Maybe you choose to come in every year and then do the rest of your programming remotely over the internet in these in-between visits if you live far away from a center, or if it's really inconvenient for you to come into the doctor. The Boston Scientific device is the only one at this point that's delivering image-guided programming that allows your MRI scan to be uploaded directly to the doctor's programming device, so that that doctor can see in 3 dimensions what your specific anatomy looks like and where the electricity is going. It's also a highly flexible device. The Medtronic device is the only device right now that can record brain signals. So in addition to stimulating with electricity, we can record signals from the brain. That may be more useful in 1 to 2 years as we're getting more and more information and we're doing trials of how to use that kind of capability. The Abbott device, relatively less flexible, although it's minor. The Boston Scientific and Medtronic devices, relatively more complicated to program, although again, that's minor. And so the most important factor is what device likely your physician is comfortable with. And if they're comfortable with all three, you can refer to some of these advantages and disadvantages. The other thing to choose is whether you go for a battery with a single charge or you go with a rechargeable battery. The single charge batteries are convenient. It's a set it and forget it device. You implant it, and then you have to take it out every 2 to 5 years and replace it with another single charge battery. So that's really nice for people who just don't want to think about it anymore after they undergo the surgery. The rechargeable batteries last longer. So the best of our knowledge is that these last at least 10 to 15 years. They're also thinner because they don't have to hold the same amount of charge over 2 to 5 years, but they do have to be charged every 2 to 6 weeks, depending on the manufacturer. So that gives you a smaller device, a thinner device, fewer surgeries, but requires you to charge the device. And the way that you do that is to use something that is a lot like an inductive charger that you would use for your iPhone. It's a little pad that sits over the battery while it's in your chest. You're watching a movie, you're watching television, it just sits there, and over the course of about a half an hour or an hour, it charges the battery through your skin. So the smaller batteries are rechargeable, and the smallest battery that's available by a pretty wide margin is this battery from Abbott. But all three of these batteries are relatively thinner and lighter than the single charge batteries. So this is a factor to consider. That's really only important if you're a really thin person, you don't have a lot of fat under the skin, or you're really concerned for some reason about the aesthetic effect of having a battery in your chest. That could be a reason to consider the rechargeable devices. So there's no best option. This is all guided by your specific symptoms, by discussions with your doctors, your goals, and your priorities. And the important players in this decision are you, your neurologist, and then your deep brain stimulation team, if that's a separate person. All three of those people need to be communicating. So then quickly in the remaining 5 minutes or so, I want to cover new and future innovations. The first one I've hinted at is image-guided deep brain stimulation. This is provided by the Boston Scientific device. You can see these yellow, green, blue, red bubbles on our physician programmer. This is the tablet that we use to determine where to send the electricity and do the programming of the device. These three-dimensional reconstructions are your specific anatomy. This is not a general, atlas-based picture of what your anatomy should look like, but this is reconstructed from your individual MRI. So this allows us to know with some degree of certainty, not 100%, where we're sending the electricity. Sometimes there's a lot of assumptions in how this three-dimensional reconstruction is made that are not fulfilled. And so there's error in this process, but it's still a very useful tool for us to have. In the future, we may, in addition to being able to reconstruct elements of your anatomy, be able to reconstruct the wiring of the brain, which right now we can't do automatically from the MRI scans that we get. And so not only can we see what nerve cells we're stimulating, but also what wires we're stimulating, these axons that connect different areas of the brain. So this is something that's coming down the pipeline for the future. The second thing, and this is should what I should tell you is not currently FDA approved, is adaptive deep brain stimulation. So these are the slides that the sponsor of this talk suggested be indicated as different in that the other things in this talk are currently available, and this is not currently available. It's coming down the pipe. It's right now it's a research, largely a territory of research. So adaptive DBS uses this concept of a closed loop system. And the one that's most intuitive to people is your thermostat and your furnace. So the input to this closed loop system is the ambient temperature of the room, and that feeds back to the thermostat, which connects or disconnects based on the ambient temperature and turns on and off the furnace. The furnace heats the room, it turns the thermostat back off, and that disconnects the flow to the furnace. So this closed loop where you have an input signal triggering an output signal is the concept behind adaptive deep brain stimulation. So for DBS, your input signal can be the amount of tremor that you have on your wrist, or perhaps signals that come from the brain that we can sense using some of the DBS electrode technology that's available now. And then the output is the strength or specific configuration of the programming. So how much stimulation we apply, or the way in which we apply the stimulation. And that can feed back then to reduce the tremor signal, or perhaps the electrical signal that we're reading from the brain that can then feed back again to change the way that the deep brain stimulation is delivered. One of the devices is now currently capable of reading signals in the small area of brain tissue around the electrode itself. And this is the basis for some ongoing studies of closed loop or adaptive deep brain stimulation. The ADAPT PD trial was presented in Copenhagen in 2023 and showed that using this technology, using this concept and technique, we can have a similar amount of symptom control with possibly less energy usage. And there's ongoing studies to show if we can maybe affect better symptom control in certain situations. Although, again, this is not FDA approved, and this is something that's coming down the pipeline likely in the next 1 to 2 years. So we can currently, using the existing technology, sense brain signals, but we cannot change the stimulation based on those signals as of yet. Third technology available now from Abbott Labs is remote programming, and this I already mentioned, but this is what it's going to look like from your physician's end and from your end. You have your DBS patient programmer, which is basically an iPhone. You can see your doctor as you're connected with this iPhone at home. Your doctor has a tablet. They can see you at the other end of that connection, and then securely and remotely over a secure portal, they can connect into the battery and change the programming of the device in order to improve your symptoms from home. So all of these are really useful recent technologies which have been developed, and also some coverage of stuff that's coming down the pipeline. This is my email address for anybody who's interested in contacting me or asking me further questions, and I'm looking forward to taking questions during the question period in a few minutes.
Thank you, Dr. Mason. I really appreciate the way that you speak so clearly and thoroughly through the whole process of DBS, what to consider and what not to consider. And yeah, really appreciate the way that you just presented that material. I'd like to now share a little bit about our next panelist, Margaret Cohn. Margaret was diagnosed with Parkinson's 12 years ago and managed her symptoms through healthy living and unique self-developed techniques, which we'll talk a little bit about here in a moment. And for a decade, Margaret used this approach to help her maintain her quality of life. However, about 2 years ago, her symptoms began progressing rapidly, making daily life increasingly challenging. When traditional methods were no longer effective, deep brain stimulation became the option for Margaret. The decision was very clear. It was a no-brainer, using your words, Margaret. You underwent DBS surgery April 3rd, 2024. Is that correct?
Correct. Yeah.
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 So, Margaret, if you would share with me, what were your first signs of Parkinson's, and how did you approach the diagnosis in the early years?
I first noticed it, I was actually walking up to work, and the parking lot that I parked in had a slight incline. So normally your movements of your arms would be both sides to get you up the hill. Well, I noticed that my right arm was heavier than my left, and it just hung there, didn't move with this, with my left arm. And being a nurse from a long time ago, I thought to myself, that's something sneaky's going on here, and it's possibly Parkinson's. So my doctor referred me to a neurologist, and he confirmed that it was Parkinson's.
Mm. When we were chatting last, you shared with me your concept of using arithmetic to counterbalance Parkinson's. Can you share some of the activities that helped you stay engaged and resilient through the diagnosis of Parkinson's using arithmetic?
Sure. Well, first of all, I really give credit to my mother. She was my first educator, and she used flashcards. And I can remember her saying to me, with arithmetic, you have subtraction and you have addition. So I remembered that being diagnosed with Parkinson's, and I thought to myself, this is a very sneaky disease. It's going to take away some of these quality of life things that I'd use every day. And I thought to myself, the first thing it's probably going to take away from me is my walking, my muscle control, my I don't know, the exercise routine that I have. So I decided that it had subtracted that from me, and I was going to add on to my daily life climbing mountains, because I would have to walk, I would have to exert myself, I would have to use my muscles, I'd have to get up to the summit, I'd have to do this. So I applied to climb Mount Kilimanjaro. And so I did that twice. I don't know where my mind was, but it was definitely, and I think I left a lot of my heart on Kilimanjaro as well. It was a great experience. And I use that every day. When I think to myself, you know what, I can't do this. Well, I did it. And it is a way of putting back in adding to the arithmetic that Parkinson's has subtracted. So I do that continually. If something I notice is taken away from me, for instance, I knew that speech could possibly be a problem. So I decided to open up a podcast, because I would have to speak. I'd have to use those muscles of speaking, and I would have to engage myself with people. So it really was giving back my quality of life. And I did that for, 8-10 years. I managed it through arithmetic.
I'm hearing this metaphor of climbing the summit, that where you literally scaled Mount Kilimanjaro, and every day, right? Parkinson's visits us in a different mood and a different tone every day. So using this metaphor of what mountain am I climbing today?
Yeah, absolutely. Absolutely.
Margaret, thinking about leading up to the procedure of deep brain stimulation, what led you to the decision of pursuing surgery? What was your experience like before and after the procedure of DBS?
You know, it really boiled down to what had and was Parkinson's affecting the quality of my life. So I put it down to imagine the normal person would imagine not being able to tie their shoelaces, not being able to take a fork of food to their mouth, not being able to cut vegetables or cook, not to be able to read. You couldn't sit still. What can you imagine having no social functions because you were hesitant to interact with people because you didn't know whether your switch was going to turn on or your switch was going to turn off. So imagine those, what you think are little things in your life. Imagine not having those. And every single day since my DBS, there are things that I sit down and I go, I just did that. And I did it sitting still. I'll never forget reading a book. I was sitting on this couch and I was reading a book, and I suddenly dawned on me that I hadn't done this for about 10 years. I hadn't sat still and held a book in my hand and was able to turn the page. Just so it's DBS has given me the quality of my life back. It has allowed me not to manage my symptoms. It's taken away that responsibility, which is great.
What advice would you share with others who are facing similar challenges?
I would really say first of all, you got to understand that this is a progressive disease. So regardless of whether you got DBS or not, it's going to be progressive. And that's the wonderful thing about DBS. And I try and tell people that it's not a cure. Obviously, it's not a cure, but it is a way that you own this disease and you can do something about it. And the reason why I say it was a no-brainer to me, because I didn't have to think about whether I was going to have this done, because the quality of my life would be so different having this. And it has. I mean, I say to people, I can't understand. I actually get sort of mad if they hesitate. I said, if only you could see me a year ago and see me now, you would say, I want to try that.
Thank you so much, Margaret, for sharing. And I'll ask you to stay, and I'll invite Rich to return. There's a question that keeps surfacing with our community who's present with us today that I'd like to ask both of you. Our attendees are curious what recovery was like. How long was your recovery? What did it feel like? Did you have any side effects from the surgery, difficulty speaking or problems with balance? So if you could just share a little bit what recovery was like for you both.
Ladies first.
Okay, thank you. I think because I'm such a curious mind, that the recovery was not that it wasn't fast enough. It was, okay, what's the next step? What do I need to do next? My recovery was excellent. I was actually, the day afterwards, I got to go home and I got to go for a walk in the afternoon. So it was a very pleasant recovery.
Thank you, Margaret. How about you, Rich?
Pretty similar for me. My first surgery, because I had it done in 2 surgeries. First surgery was a breeze. I mean, I was home the next day. A couple of days, I was back to Zoom calls and working and producing a show. It was really quite amazing. Like, I almost had to stop myself from doing too much, because it's like you just feel like you're invincible at that point. It's great. You feel so good, so great afterwards. And the second time, the fun, I don't want to say funny part, but my parents were gonna take care of me a little bit after the surgery. And they ended up giving me COVID directly after I had right after I had the surgery. So I had to deal with the COVID, which was far worse than anything that was part of the recovery from the surgery. Was like nothing at that point. It's like it was just I had to change a bandage. Dealing with the COVID, and that was far worse. So it's not. I survived it, obviously, and still worked out to my benefit, the surgery and everything. So I don't hold it against my parents, but don't recommend that.
I don't know about Rich, but I was very excited about what came after the surgery. So, I had staples in my head and I wanted them left there because it was like badass. I've done this. I've accomplished this.
I try to show off my scars a little bit. So I was the same way. Definitely. First surgery, was a little different because it was the first one, and I was dealing with that. And but I mean, immediately when I felt so much better, it was a miracle. Second surgery, I was like, let's go, come on, bring it on. I said,
you knew what to expect.
Put me on the waiting list. They had me for 3 months down. They pulled me right up like 2 months earlier, and I said, let's go. I'll make myself available whenever. And we did it. And it was nothing except for the COVID, but.
A nice follow-up question just came through, comparing the process of preparing for the surgery being more difficult than the recovery post-surgery. Would you agree or disagree?
I didn't feel that the pre-prep was, it was easy. I mean, I remember my Abbott nurse saying to me, I'm going to be the last thing that you see before you go under anesthesia, and I'm going to be the first person you see. And she was. And that made the biggest difference for me.
Yeah, the certainty, the consistency.
Yes.
Thank you for sharing that, Margaret. How about you, Rich? Do you feel that the pre-op was more more preparation and
I mean, it was an MRI,
yeah.
and some blood tests, and really, I mean, the doctors do all the hard work. We just had to be put to sleep and wake up and feel better. So I mean, it was the pre-op is nothing compared to, you know, the entire pre-op through the surgery to the recovery is just, it's absolutely crazy how quickly it all goes and how easily it all goes and how great you feel after. It's just, I doubted it for a second. So again, I didn't know so much about it, but after the first surgery and the second one, like I said, let's go. I'm ready to go tomorrow. Let's do it. So
I'm glad Rich said that, because a lot of people ask us, what is it like? And I hesitate, because I think sometimes I make it sound like it's euphoria. Not, it's brain surgery, but I can't remember a downtime. I don't know about you, Rich, but I can't remember any time going, why did I do this?
No regrets whatsoever.
Well, thank you, Margaret and Rich. Really appreciate you sharing your courageousness with our community here and the way that you inspire us to do what's best for ourselves. I appreciate you both.
Thanks for having us.
Dr. Mason, I have just a few questions I'd like to offer you. Our community, there's some theming around the questions that are coming up, so if you'd let me indulge you for just a few more moments. One of the questions that keeps bubbling up is a concern around genetic markers. Are there certain genetic markers that make for better success with deep brain stimulation?
At this point, no. We're collecting more and more data on genetics and how deep brain stimulation is affecting specific people with specific genetic changes, but we don't have enough data to say that one genetic mutation is going to respond better than another. There's some early data to suggest that people with mutations in GBA, that's glucocerebrosidase, might be at a risk of more cognitive changes after deep brain stimulation. But even that data is preliminary. And what we see just from the general epidemiology, from the general population studies, is that people get benefit, and people get benefit for a long period of time. So we'll be understanding more and more of that. But at this point, there's not enough certainty to say.
Just quickly, is DBS covered by insurance? Do you know that?
It is.
It's great.
Yep. All major insurers are going to cover this. They're going to ask for some specific things from your doctors, which we know what those are.
Yeah. A question that one of our audience is writing in, they say, if we know that Parkinson's disease will progress to a point where meds are not as effective, why not do brain surgery sooner rather than later?
Right. Well, that's a question that's actually being directly addressed right now by some investigators on the East Coast. That I'm not going to get into the details, but those trials are ongoing. And the answer to your question is that if medications alone are providing you good symptom benefit, then it's a lot less risky than surgery, because Parkinson's disease doesn't always progress to a point where the medications are not enough. Yes, it often does, but it's by no means is it a certainty. And so it's usually safest and most appropriate to see that the oral medications that we know are safe, we know are well tolerated, and that come at a much lower risk of any side effects. We want to see that those work, and they may work for many, many years before surgery is necessary. So,
Dr. Mason, any final words that you would wish to share with our community before I let you go?
well, yeah, I would say be very open to the experiences of many people who have had this procedure. Try to learn from a diverse community of people that have undergone deep brain stimulation and those who haven't. If you have access to a support group, use it. Try to speak to lots of different people and consider the input perhaps of different physicians. If you have a specialist who's not really comfortable in deep brain stimulation, maybe seek a second opinion. If you go to a center and you're not completely satisfied with the amount of education that you receive, go to a different center. So take your time and front load your time and make sure you've done your research with all the appropriate people. The other thing that I would say is the most important thing in achieving a good outcome and being satisfied with the surgery is a good match between your expectations and what the surgery can deliver. And that comes with education. So make sure that people are giving you all the right information, that you understand what to expect. Because the people that have the most accurate expectations are the people who are happiest after the surgery.
Managing expectations, doing your research, staying connected and supported.
Thank you.
Thank you, Dr. Mason. I appreciate you. And thank you to all of you for sharing your time in today's program. A big thank you to Rich and Margaret for sharing their time and expertise. And before you'd go, I'd like to share some resources with you. Firstly, just wanting to acknowledge our sponsor for today, Abbott. Understanding their partnership makes a meaningful impact, and because of their generous support in helping us advance our mission, thank you, Abbott. If we didn't get to your question, or if new ones came up as you process the information, we're here to help. You can visit our website at parkinson.org for a wealth of resources on Parkinson's disease, or reach out to our expert team directly. You can call our helpline at 1-800-4PD-INFO or email us at helpline@parkinson.org. We're ready to support you every step of the way. And as we wrap up our time together, I'd like to take a moment to share some important information about research. The Foundation remains dedicated to educating and expanding opportunities to deepen our understanding of Parkinson's disease. Your engagement in Parkinson's research plays a crucial role in advancing treatment options and bringing us closer to a cure. I'd like to highlight a few ways you can get involved and help drive progress in Parkinson's community. Our PD Generation study offers free genetic testing and counseling for Parkinson's-related genes to people with Parkinson's. This groundbreaking initiative is helping us uncover more about the genetic factors behind Parkinson's disease. By participating in PD Generation, you can learn if you have a genetic link to Parkinson's with no long-term commitment and full confidentiality. The genetic test results can provide valuable insights into your symptoms and potential progression, helping you and your care team create a personalized treatment plan. This study is also advancing research by helping scientists understand why experiences with Parkinson's vary from person to person, and to achieve this, it's essential to have a diverse participation. We understand that diversity is key to building a comprehensive understanding of Parkinson's and ensuring that future treatments work for everyone in our community. If you're interested in participating in PD Generation, you can call our helpline at 1-800-4PD-INFO or visit the website on the slide. And know that your results can empower you to make informed decisions about your treatment options and even open the door to participating in gene-specific clinical trials. And now shifting to another opportunity to push research forward, the Parkinson's Foundation is proud to partner on Persevere, a new NIH-funded study for family caregivers of people with Parkinson's disease experiencing cognitive changes, hallucinations, or dementia, or caregivers of people with Lewy body dementia. This entirely virtual study explores how caregiver-centered education can improve knowledge, confidence, and health outcomes. Caregivers can participate from anywhere, at home, in the office, or on the go. And if you'd like to learn more, you can see if you qualify by visiting the Persevere website, scanning the QR code on the screen, or emailing persevere@rush.edu. Let's support caregivers and spread the word. And before you go, we have one last favor, one more thing to ask. Your feedback is essential to shaping the Foundation's programming. As the webinar concludes, a survey will pop up on your screen. Please take a moment to share your thoughts and let us know what topics you'd like to see in future sessions. Thank you so much for joining us today. We are honored to have shared this time with you and hope you found the information and resources helpful on your journey. Please know that you are not alone. Our community is here to support you every step of the way. Your strength, resilience, and dedication inspire us, and we're grateful for the opportunity to be a part of your journey. If you have any questions or need additional support, don't hesitate to reach out. Together, we can navigate this path and continue building a brighter future. Thank you again for being with us, and we look forward to connecting with you at future programs. Take care and be well.